are. Right, hopefully we're not on our,
Take two. Hello everybody.
heads.
It is Thursday. This is the infant feeding team. I'm Naomi, this is Alex. We're part of the team at the John Radcliffe Hospital, and we are doing our infant feeding session, which is for about an hour, on anything to do with feeding your baby. So we love your questions, and we always get fantastic questions, and hopefully we'll have lots of you watching again and wanting to know lots of things, or supporting you in questions that you may have been brewing for a little while. Things are a little bit calmer on the ward in the last few days. It's been exceptionally busy, and those of you that have just had a baby will know that, because you will have been on the ward seeing the busyness. But we're carrying on as normal. So we've had a busy clinic this morning. We've had lots of mums and babies in. We're sort of full to bursting in our infant feeding clinics at the moment, because we seem to have lots of stuff going on. So if you want an appointment, be patient with us. We are trying our hardest to get to see you, but we work on the wards, we work in clinic, and anywhere else in between. So some of you might have seen us on the ward as well, supporting mums. So I hope you're all well. I hope you're all managing in COVID still. It's ongoing, isn't it? And things are relaxing a little bit, but we all have to be careful again, and hopefully you're all protecting yourselves well and managing to stay well. We know that lots of little children are getting COVID at the moment, aren't they, in nurseries and in primary schools and things. So you know, it's the age group where you've got children at nursery school, at school, and you're having babies. So there is a higher risk to you all if you have got small children or you're working in schools or whatever. So if you've got any questions about that, do call us. Do message us. Put the questions down there. And if you are weaning, or you are giving bottles or giving formula, that's what this session's for. So not so much about your birth and water births and visiting times and scans and things like that. So please do ask us lots of questions and see if we can help you. So have we got any questions coming in?
Well, we have. So apologies for that beginning. So it's quite funny because it's come up on the screen. I can see it that we've come up sideways. There's you chatting away, me really running around sorting it out. Anyway, Gemma's come on and said, not a question, but Naomi, you were great help with both my tongue-tied boys. Thank you.
Thank you. Glad to hear. Thank you.
And Charlotte has said, hi ladies, hope you're okay. Alicia says hi and is waving at you both. Hi Alicia.
Haven't seen you for a bit. I've been absent, so it's nice to be back. Right,
no, that's it. That's just the two. So hopefully we'll have a few more in a minute. So
yeah, so we always write little bits down to start to talk with, just to see how things are going. But so I've written on my little list. So I think one of the things that, well, we've got several things that we're going to talk about today, but I think one of the things that we want to and always do get across is a second night. So when your baby's been born, and then the next night, when you probably have gone home, your baby grows horns, and we talk about it a lot, don't we, Alex?
Yeah, I met
horns at 8 o'clock.
Met a mum in that situation the other day, and said to her it was very normal.
Yeah, and they are very, very busy, so they tend to be much more sleepy during the day, and babies wake up at 8 o'clock at night because they're chasing the milk, and the hormones are higher at night, and you know, babies want to feed. Their clocks are the wrong way around, and you may have noticed that actually when you were pregnant, that your baby was wriggling about inside your tummy when you were trying to sleep, and then seemed quite calm at home when you were in the house and resting or busy. It was much more asleep, and then you worry that your baby's not moving, but they are busy at night. Yeah. And you know, so they open their eyes and they really want to feed, and certainly, you know, there's sort of any medications you've had, anything, you know, if you've had a long labour, you tend to, your baby tends to be very tired, and it's sort of nearly 48 hours after you've delivered, they usually start to wake up and show their true colours. So it's recognising that and knowing that it's normal, but also they're getting to the stage when their milk is starting to think about coming in, and you might find that your breasts are a little bit marbled with veins, very veiny. They may feel a bit warmer, and they may have got a little bit bigger, and that's the start of your milk coming in. And that happens when you've had your placenta delivered. The messages start to go to your brain, and so your baby gets the colostrum initially, and then as you feed and you take the colostrum off and you feed and you hand express, then messages are sent to the body to start to produce milk, and you start to think about getting transitional milk. But on the second night it's not quite there, hasn't quite come in, so it's usually the next day that it would come in. So your baby's chasing it, so they just feed and feed and feed and feed and feed and feed and feed. And if you don't get your positioning and attachment right, then you get sore, and you get upset and stressed, but also your baby doesn't feel that it's satiated, and it's at 4 o'clock in the morning that you send your partner away to go and find something else to give your baby. And actually you don't need to do that, because your baby is normal. So they might only do 3 P's or two P's that day, and that's okay. And they may have a little bit of brick dust, a little bit of urates in the nappy at that point, and that's also okay. And they may be pooing, but they should be pooing, and they should be doing meconium, sort of getting slightly less sticky at that point, so it comes off the bottom when you wipe it. But they should be pooing, and you should see some wee as well. But they should be feeding all the time, and you think that you've got no milk and the baby's not happy, but actually they're doing what they should be doing as babies, which is chasing the milk supply and telling the body to start making it because they're ready to have it. One of the things you can do is what we call compression. So if your baby's at the breasting, you can hold your breast when your baby suckles, and then when they pause you can let go. So they might be doing they might be feeding like this, because this is what babies do on the second night. They're going like this all the time, but actually you can compress, and that sometimes just pushes more colostrum in from deep within your breast.
Yeah.
And you might see the baby's suckling pattern change a little bit, and slightly slower and deeper a little bit. So it's all beneficial, because that is like pumping as well while you're breastfeeding, and that really gives more messages to your baby to have more food, and it really helps the stimulation. So there's lots of tricks that you can do, as skin to skin, skin to skin, skin to skin in between. And take your baby for a walk in a sling with you, comfort it, and be reassured that it'll pass. Your baby will then start to get food, and your milk will start to come in, and then your baby's suckling pattern will change. But actually, if you're in hospital, it'll happen. So don't ring the bell and ask for extra milk, because that will just dump down your supply, because your baby then won't be doing what it should be doing, which is stimulating your breast constantly to ask for milk. So if you give your baby a large amount of food at that point, it's not going to play those behaviours out, and it's not going to put the order in for when it needs it. So that's the beginning of your milk supply going down if you're not careful.
I met a mum earlier this week who had rung the bell at about 8 o'clock in the morning. I was going to one of the meetings, and she'd asked for some formula, and I asked if she'd given any before, and she said she hadn't, but she'd been awake all night with the baby, looking for food constantly. So I asked her about how old was the baby, and this was the second night. So exactly what Naomi's saying, this was the night when the baby grew horns, and that's exactly what I told her. I said, I bet your baby slept the first night, and now this baby's unrecognisable, has been awake all night demanding food from you. And I said, but actually you've got to remember, your baby was a gorgeous, lovely, chunky boy, beautiful. He doesn't need lots of food, but what he's looking for is that closeness and comfort. It's a lot more than just food at this stage.
Much more than.
So he's looking to be close. He doesn't really understand the world that he's been born into, and he wants to be near you and close to you. He doesn't understand that if he's in a cot, he's safe. So I said to her, well, look, he doesn't need food. You've given him food all night. He's absolutely fine. I said, is your partner coming in imminently? And she said, yes. I said, well, how about you hand your baby to the partner when he comes in imminently, and you get an hour's sleep, and then rethink whether you want to give a bottle of formula or not. I said, or you could have a go at expressing. So she did agree to do that. I didn't catch up with her later, so I don't know what happened at the time, but just to say, it is really, really normal, and it's finding coping strategies, and if you know it's normal, it's much easier to deal with. So if you go into it, for those of you who haven't had your babies yet, if you go into it thinking, okay, the first night they're probably going to sleep, the second night they're going to be awake all night, be ready for it.
Have a sleep at 6 o'clock in the evening, so that you're ready for the first part of the night at least. Because they really do stretch your patience at that point, but they should be doing that. That's normal physiology.
But don't think you haven't got enough milk. It's not just about food. It's not the only thing they're after. They want that closeness and comfort, which we've talked about before, is brilliant, because that closeness and comfort, much as it's really hard for you as the parents, it's brilliant for them to have you responding to them, because it's really good for their brain growth, because there's going to be lots of oxytocin flowing through that baby's body, lots of oxytocin fertilising that baby's brain, reminding that baby's brain that you are going to be fantastic parents, that you're going to meet their needs, and that they can rely on you, which is all really important.
Yeah, they're telling you they're here, you know, they've arrived, and that shaking your world. But actually, it's what's expected of them. So, you know, as long as you know it's normal, you won't panic. But so many people don't know it's normal, or don't hear what we say when we do say it, because you're bombarded with information, and you might have it when you do your parent craft session at 32 weeks and forget about it. But be reassured that it's normal, and your baby should be doing that, and it's normal physiology to make milk. And if you do interfere with it, it will impact your milk supply, and this is when you start. Then your baby starts to get quite cross as well, because it's had a big feed, might have had 5 or 10 meals of food, which is quite a lot for a. It's a shame we're not to do this, wouldn't it?
We do it every week.
I've got my marbles out. It'd be a shame not to show you.
I didn't even be playing our marbles at our age with marbles.
But your baby's tummy is tiny, and you don't need to fill it. This is, you know, your newborn baby's tummy size. So, you know, if you put 10 mils in there, that's quite a lot. And
Yeah.
it stretches it, and then your baby's not going to get that back, you know, because you haven't got 10 mils of colostrum. You know, he's going to expect it, so he will get much more impatient with you know, with what you're doing, but it also will just spoil that pattern of calibration, which is so important when you know, he's starting to change and starting to emerge, and you're starting to get used to each other. You don't want to be disempowered thinking that you can't feed your own baby, because you know you can, absolutely you can. So trust your bodies, because you've made a baby, you can feed a baby when you've had your baby, and your milk should appear. And you know, if you're worried about anything, have we got lots of questions?
No, just a few.
Okay.
Yeah.
So if you're worried about your baby, you know, look at the whole picture, and in your care plan when you take it home,
They're going to be on the
yes, they are,
floor.
aren't they? Let's see. In your care plan when you get home, you can look at the pages.
I talked about this last week.
Absolutely, and we can't talk about this one enough, but this has certainly got the 3 reliable signs of milk transfer. So is your baby suckling and swallowing? This is the first, this one at the top is the first 72 hours. So this is the one that you would look at if your baby is less than 3 days old. And you look at all the questions that it's asking you, and if you're ticking them as green, 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 then you're doing a beautiful job. If you're ticking some of them as yellow, it might be that you need to call your midwife team and ask them a few questions, and then they could say, well, you know, maybe we should see you today. And because that is, you know, it's putting the sandbags out before the flood. It's stopping the problem from happening, because you're being proactive as parents, and I think that's really important. So you're looking at those reliable signs. Is your baby suckling? Do you hear your baby swallowing at times? Do you see wee? Is your baby's poo getting different from when it was first meconium? And you know, are you able to feed your baby at the breast and you're not too sore? And if those questions are all answered properly, you know, well, then you haven't got a problem. But if there's things going over to that side, or there's more ticks on that side, then you absolutely should be talking to somebody. But it is your responsibility. You're the ones that need to phone. It's you that's feeding your baby, and it's you that's making decisions about feeding your baby, and giving it more food, and also you know, getting and asking for help. And I say this every week practically when I do it. We're not psychic. We don't know that you're at home struggling, and we don't know that you're on the ward struggling unless you ask, because if you've all been here, you know how busy and full on it is. They're not going to come around and ask every single one of you all of the time if your baby's feeding okay. What we need is you to call us and say, I need some help to feed my baby. If you're in the community, you need to ring them up and say, I need some help to feed my baby. I've ticked the boxes, I've looked at the care plan, I'm ticking some of the yellow boxes, it doesn't seem right to me, how can I get some help? And then, you know, you will get sorted much more quickly than waiting till day 5, which is when the next visit might be, and the baby's lost more weight, and it's not been pooing, and it's you know, you're sore, and your milk's not come in properly, and then you have to start, you know, a bit of crisis management and backtrack. But the sooner you call us, the easier it is to change what's happening and make milk. So if you leave it, then it takes longer to make that milk, and it takes longer to climb back up to where you should be. So be proactive as parents. Don't worry that we're too busy and we can't see you. Make a call, get some help, make sure that you're reassured that your baby is okay, and if you're not reassured, then keep calling. That's the most important thing. And listen to your instincts, and if your baby's not feeding well, if it doesn't seem very well to you, it's a bit floppy, it's not waking up regularly, then you need to be talking to somebody. But it's being proactive, isn't it? And taking the responsibility as parents from day naught, because that's a really, really, really big thing. Suddenly you've got to be in charge of making decisions as parents, and that is quite stressful for an awful lot of people. They don't know what to do, and making decisions about increasing volumes if you're giving food. It's all about how your baby's behaving.
Should we move on to some of the comments?
I think so.
So Charlotte has said that her little lad's had COVID for the second time. Poor thing.
No.
But he's getting better now, and Alicia's very cheeky these days, and her confidence is building. She's a little cheeky monkey. I've loved the pictures. Sharon said, hi, lovely ladies.
Hello, Sharon.
Jenny has said, is it true that porridge oats help with milk production?
Anecdotally.
Yeah. There are a number of things anecdotally, but there's not research to support these things.
Lactation cookies, and I think they're mostly oats, aren't they, and things.
Yeah, I don't think there's anything to support them though. I think if you go and look at other lactation consultants, they'll debunk them. So, the best thing you can do to produce milk is good milk removal. That's absolutely the key to it.
Yeah.
So if your baby is not feeding in the early days, you get your hand on the breast and get expressing, because it's the efficient milk removal that drives the milk supply way more than anything else.
And I think, lots of mums come to us in clinics with low milk supply, and they say, well, I've heard you can take a medication to help make your milk, or that I can take these supplements or whatever. You can take all of those, but if you don't do the things that Alex has just said, none of that will happen. So you can take medication, but you've got to pump like billy-o, and you've got to stimulate your breast like billy-o 8 times a day to make milk. It doesn't happen just by taking a magic pill. Life would be too easy if that happened, and it's not like that. It's all about stimulating, taking milk out, and that increases the order to make more milk.
Yeah.
With or without medication
or
supplements.
Our bodies like to conserve energy, so unless you're asking for the milk, the body doesn't think you need to make it. So you have to tell the body that you need the milk. And when I'm talking to mums, I'll go, and you need to tell that it needs more and more and more. So it's that real push the supply. So
once you've made that supply, then it's secured. But also, when you get to about 6 weeks, the volumes doesn't go up that much, So you're giving the same amount of milk to your baby at 6 weeks as you probably do at 6 months. But the composition changes. So as your baby's needs change, so as they mature and as they start to crawl around, or they start to put things in their mouth, or they start to sit up, then the composition of the milk, it changes at those milestones as well, so that there's different fats, there's different nutrients in the milk, there's different enzymes in the milk to meet each of those stages and accept the next phase that your baby's going to go to. It's very, very clever.
Yeah, it's amazing. I always say to mums, you can't imagine, if we thought that the milk supply had to keep going up and up, we'd just explode, because you wouldn't have the capacity. Certainly not me, anyway. So anyway, Leanna said, hi ladies, not sure if you remember Alex, but I met you in the corridor last week on level 5. I do very well remember meeting you. I was slightly starstruck having watched you for so long, and then actually meeting you, or just full of medication, haha. Anyway, I just wanted to thank you both for all the advice given on your lives. I've watched you throughout the pregnancy, and I've successfully started myself. My breastfeeding journey by myself, thanks to you both, true angels. Thank you. He has a tongue tie, but we're still able to latch using different positions, and we're day 12 now and still going strong. He's my 5th baby, but first accessible breastfed, as back then there wasn't any support. Thanks again. I do remember meeting you. I met you outside Bay 14. We were on the corridor and we had a quick chat, and I said, what was your name? It's nice to see you. Right.
Well done you.
Yeah, keep going. That's great news, and I think that's inspirational for anybody else watching.
Absolutely.
Charlotte's come with her food for before one is just for fun. Indeed, Charlotte, indeed. That's for anyone
listening to us.
Yeah, anyone who's thinking about moving on to solid foods, complementary foods at 6 months. Just remember that your breast milk is the main source of nutrition right through to the first year. So thank you for that, Charlotte.
And Leanne, if you've had 5, it can't be that bad. You're reassuring everybody else that are having their first that it's not so bad if you can have 5.
Rachel has said, colostrum harvesting, is it always possible from 37 weeks, or does it vary when it's possible to start? Well, we don't recommend before 37 weeks because there's a very tiny, weeny risk it could put you into labour, and we don't want any premature babies. But it's very variable as to how much you'll get, if any. So everybody is different. So, you know, have a go when you get to those 7 weeks, but unless we know for certain that you're going to have a premature birth, and it's all within the agreement with the midwifery and the obstetricians, that's the only time we would do any
if you're
expressing.
being induced that day,
prior.
You can do the induction. If you're before 37 weeks and you're having an induction or a cesarean that day, you can do some while you're waiting, and it might enhance your labour. And if you're waiting for a cesarean, then obviously you can do some hand expressing before. So you've got a little bit to give when you've had your baby.
One of our doctors is doing some research into this. She's just she's put a paper together, and we will be, supporting mothers who, if we know for certain they're going to be having their baby early for one reason or another, supporting them to express. But for the rule of thumb, please don't express before 37 weeks. Hopefully that answers your question. Rachel's then gone on to say, are there any symptoms when you might be ready to start? Well, some people start leaking from really early on, don't they?
From about 16 weeks you can have milk leakage, and you might just wake up in the morning and have a big blob on your nightdress or something, but that's not needed. It doesn't mean that you're not going to make milk or you are going to make milk. It doesn't make any difference.
But we don't want
you are what you are.
We don't want you expressing. So because there is this small risk of going into early labour. So hold off till 37 weeks, please, and then 4 times a day. And if you go on our website, and I say this every week, if you look up OUH feeding, OUH maternity feeding, if you literally put those 3 words in, up comes our page, and there's a link to a leaflet that we put together about collecting colostrum when you're pregnant. So you can have a look at that leaflet that talks all about it. We've got a great video as well, haven't we? On our we've got a video
it's
of a
really
mum.
real life that we filmed in one of the rooms on level 5, didn't we? You did that, and in fact we did some teaching yesterday and showed it in our teaching, so that it's really nice for staff and for mums to see mums properly hand expressing, because we often demonstrate it on these woolly balls, and it's just not the same when you don't see the milk coming out or seeing the way that it's done. And actually the mum that's doing it is really confident, and she is quite early on, isn't she? Day 2, end of day 2.
It's just what we call transitional milk, because it's just beginning to drip. It's not colostrum per se anymore. Colostrum is thick and gloopy, as we've always mentioned. It
glistens rather than looks white.
And it can often be very yellow, and it collects in a sticky droplet. Whereas when you get into the transitional milk, it starts looking a bit more like milk, and it starts dripping, whereas colostrum doesn't really drip in the same way. So it's a great video, and we were very lucky.
Milk squirts out, and she gets such a shock because she hasn't seen that before, and mostly it's tiny little bits, and she shows you how she's collecting it with a syringe. She's really, really experienced at it, and it's lovely to see. So in the way she's handling her breasts, it's really confidently. So you can see what sort of amount of pressure you need to put on your breast in order to do it, because I think sometimes mums just touch their breast and expect it to sort of flow out, but actually you've really got to tap into the ducts when you're doing it. You've really got to tap into those ducts when you're doing it and be quite firm with it, not painful.
Nice big C, work your way back from the base of the nipple, feeling for where it gets lumpy and bumpy, anchoring your thumb and fingers where it is lumpy and bumpy, and then bring them in as if they're going to meet. So you're in and hold.
Yeah, it's a good hold.
In and hold. I like the nails to go white. People are holding hard enough. If it's just a little mincy thing, it's not going to do anything. It's in and hold, good pressure. Shouldn't hurt, but pressure.
It should be a different sensation, because it's not actually something you've ever done before. Actually squeezing your breasts in a way that is not something that's familiar to you, but actually if you look at people doing it in real life, they're really quite they're quite firm, and their hands go quite deeply into the breast tissue. It's not pain, it's but firm, because that's where you want to get those ducts working, and that's, if you do that, and you've got that skill when you're pregnant, say, and you're doing it antenatally. When you've had your baby, you'll be very, very confident at expressing milk for when your baby needs it, and how to get milk out of your breast if your baby needs it. And I think that above all is, and certainly when we talked to the staff yesterday, some worked on the observation wards and on delivery suite, you know, they said it was just so helpful, and they find it so helpful on the wards when mums have done it antenatally to help them, because they have got that skill already, and they're not afraid to do it, and they know where on their breast is the sweet spot to get that colostrum to flow, and that is so helpful, and so helpful for you because you're confident already as a mother. You've got so much going on in that first sort of 48 hours when you've had a baby. You're sore, you're tired, you know, it's a huge change, and you've got another person to look after, and when you've got one more skill to learn and know how to use a syringe, which is something a lot of people have never done, it's very, very difficult, and you might have something in your hand, like a drip or something, you know, and so you haven't got the dexterity, so it's really hard to learn a skill when you've got through all of that. And you might feel really numb because you've had an epidural or a spinal, and so you don't feel yourself. But actually, if you've done that, that's normal for you, you're very comfortable doing it, then you're onto a winning streak there. You don't need to collect it antenatally, that's not you know, an obligation. But learning a skill is a really, really good idea before you've had your baby.
Yeah.
So, you know, do have a go, and it might just be that you do it when you have a shower, well, then that's it, and you don't collect it. That's absolutely fine too, but it's learning that skill that's so crucial.
Charlotte's come back and said Alicia's going to be 2, and she can't believe it where the time has gone. It's amazing.
I can't believe it.
Yeah. Rachel said, okay, that's great, so it's possible to do it after that time, but clearly there's no pressure to even give it a go.
Yep.
Thank you. I think we'd love you to have that skill, which is what Naomi's just said. Learn the skill. Don't worry about the collecting it so much unless there's a risk factor. If you get loads coming, why not collect it? But, you know, just make sure you know how to do it.
And the risk factors we talk about is if your baby's, you know, going to be anticipated to be not well, you're diabetic. I think if you've got a family history of atopic disease, it's quite crucial. So if you've got inflammatory bowel disease, you know, Crohn's, anything like that. And what's the other ones that we talk about? If your baby's going to be small, so if you've had scans and it shows your baby's going to be small, or you've had a long labour and maybe your baby's, you know, if your waters have gone and you've had antibiotics, it could be that your baby's got an infection as well. If you've got a temperature and things in labour, so you might find that, you know, that skill is something, but you probably wouldn't know that until you got to it.
No, you wouldn't know.
But any baby that's got a risk factor, particularly all of those things, and if you had a difficult time last time, you know, it's a really good skill to catch up on again. And the other thing is, if you've had implants, so if you've got breast implants or you've had a breast reduction, you might find that really helpful as well to revisit that skill.
Yeah, so you can manage.
Yeah,
when
you
the
can
milk
manage
comes
so
in.
that you, you know, learn to really stimulate your breast well as well. So,
Right.
you know, it's really helpful.
Amy has said, I have a problem with a high supply and strong neck down, but my 3-week-old baby is windy and uncomfortable. Is there anything I can do, as my first suffered reflux until after 9 months, or could it be due to posterior tongue tie? It can often be to do with that letdown. If the baby's not coping, we're going to say the usual, aren't we?
I've got the leaflet in front of me. Revisit it. Positioning and attachment. I don't know where you live in Oxfordshire, but you know, do feel that you can contact the local support to you. So Oxfordshire Breastfeeding Support, your midwife. Well, it won't be your midwife now. Health Visitor Support if they're coming to see you, and also Abingdon Breastfeeding Cafe or La Leche League. They're all really great. NCT support. Local peer support as well, but revisit your attachment, because it sounds to me like your baby could possibly have slightly a shallow latch than we would perhaps like, because they're choking a little bit, but also you feel that you've got high supply. And what tends to happen when you do that is that it creates a cycle of just oversupply, making more milk if the baby's quite shallow. So what you're wanting to do is really make sure, you can do that, I'll do this, line your baby up well. I'm trying not to make this so it's not shiny, because I did look at one the other day and it was quite shiny. So that you're lining your baby up really well on the breast, and then hopefully they can put their head back so that the nipple can go right up to the top of the roof of the mouth, and you're trying to get right underneath here in first.
Try to do it standing.
Yeah, because often if they're just in the middle of the breast, so if they've sort of got the nipple like a bottle in their mouth, and sometimes when your baby's got to 3 weeks, you don't kind of notice that you're sore anymore if you've gone past that, and so you've got used to it. But actually, you need to make sure that your baby's got their chin right underneath there, so they're getting right deep into the breast, the milk in the depth of your breast, so that you can see that they're really removing all that mix of milk, so that they're not getting lots and lots and lots and lots of full milk, or more lactose full milk, and that tends to make babies very, very unsettled, very, very explosive, windy, and very unhappy. They often gain a lot of weight, but they don't feel happy. And by moving them a few millimeters, you can often resolve that and make it much better.
Right, so that's nose to nipple.
There's always improvement in breastfeeding.
Can you do the nose to nipple picture?
That's nose to nipple, isn't
No,
it?
it's not.
That's nose to nipple.
No, that's nose
That's
to nipple.
nose to nipple.
So I'm holding this baby in such a way that the head is free to tip back. Got fingers up one side and thumb up the other, as if I can see the. You can't see my head. You can see the body, as if I'm going to wash the hair. So I'm going to bring that baby so it is nose to nipple. We had this discussion in clinic today. I was just chatting to a student, and her mother came in and she goes, "I don't understand nose to nipple." And I said, "Well, it's literally that we don't want your baby over here. We don't want to line them up chin to nipple, or mouth to nipple, or head to nipple. We want to line them up so that the nose is in line with the nipple, because otherwise we end up with babies." Yeah.
When they lift their head back, as Alex will demonstrate as well, they do that so that they sniff the air.
Yep, that baby's head's tipped back now. And then
it's lined up straight onto the gum ridge, the nipple's on the gum ridge, and it slides over the roof of the mouth.
And now I'm going to push from here, not up here. I'm pushing from there. And the movement is that movement. It's a straight movement. And if you look, my wrist is straight. What we don't want is this. And we don't want a breast moving, because you've lined your baby up and you bring them straight on, and the upper lip will skim the nipple and the lower lip will hit right at the bottom. So it's going to be like that, not like this.
And then they lift their head back, the chin really hits that breast first, and that's right underneath where the milk ducts are, and then they strip the fatty milk as well, and they get a really good mix of milk. And it is only millimeters, it's always millimeters, but it can make a huge difference to your baby's behaviour. So we always say, even if it looks perfect, there's room for improvement.
Yeah,
always.
Yeah, Amy's come back. It's really helpful, thanks. He did gain £1 pound in his first week, so that sounds like what's happening.
He likes sugar. It's very sweet. Lactose is nearly all sugar. It is sugar, and it's so filling. But it's like having soup. They have buckets of soup, and so they get lots and lots and lots, but they don't feel satisfied. So they also get very windy. And I think one of the byproducts of it, and we talk about this all the time, don't we? But the byproduct of lactose is the lactase in the tummy can't break it all down, so you get this overload of lactose in the tummy, and the lactase is going, oh my goodness me, I can't break that down, it's an enzyme. And so the contents of the stomach content acid is hydrochloric acid, but the byproduct of lactase overload is hydrogen peroxide, so it's fizzy. So what happens is the byproduct, when it's sitting there and not being able to be digested properly, is hydrogen peroxide. So you can see what's going to come. It's fizzy gas, and it makes them very, very upset, and they have explosive nappies, and they get sore bottoms, and they get tummy ache, and they want to feed all the time because they're not, they haven't got chocolate pudding. Yeah. And they need chocolate pudding or
puddings. The puddings. The poos can sometimes be green as well.
Yeah. Yeah. So revisit it. It's so subtle you can't even see it. Yeah. But perhaps get your partner to film you breastfeeding and just see how shallow that latch is, and just see if you can improve it. one of the reasons they choke is that if the breast isn't far enough into the mouth, the milk pools in their cheeks.
It's like that.
And so you get this letdown, and the milk pools in their cheeks, and they can't suck, swallow, and breathe when they've got a mouthful of milk. When a baby's on the breast well, it goes down the throat. It doesn't go in the mouth. The breast milk doesn't hit the mouth when they're breastfeeding well, only just as you're taking them in, putting them in or taking them out, and they've got a mouthful when they finish a feed, and they come off. But actually, when they breastfeed, they take the milk straight down their throat, so they don't choke. So the choking is often because they're too shallow and they're getting milk in their mouth instead of it going down their throat. So if you get them on really deeply, you'll find that that choking stops. And I had it in clinic today with a baby that was choking, and the dad was, quite anxious about it, understandably. But it's understanding that it's not normal physiology for a baby to get a mouthful of milk in order to suck and swallow and breathe well. And so if you just get that a little bit deeper, then you'll find that that will stop, and your baby can cope with the flow. And what will happen then is your supply will start to dump down. If you get the feeding right for 2 or 3 days, after about 2 or 3 days, you'll see that the supply dumps down a bit, and that it's not such a forceful letdown again, and that they settle down and they get the right amount of milk. So have a go, and just go and revisit some of the local places that you can get breastfeeding support from, to see if they can make it better for you, with you. And it is subtle, very, very subtle, but have a little film of what you're doing.
The other thing you haven't mentioned is whether this is a first or a second baby, or maybe the third baby. And it's just remembering that babies, and I have this conversation quite often, that babies want to be in close. Now when you get a baby that's older, so mums often, if they've been feeding an older baby, then come to a newborn baby, they don't remember to bring that baby in like a newborn anymore. And actually I've been saying, and it seems very appropriate this week with it being burns, think about them being a bagpipe. Get them in really close, right in close, tuck them in under your elbow so that you've got them in, so their bodies are in. It means it allows the heads to tip back. So in, close, tucked in under that elbow, round the body. What we find with the older babies is mums tend to feed them and they're out here. They're hanging off them. They're down here. And actually, if you imagine, if you're down there, you cannot get your chin in as the baby. The poor baby's chin is not in against the breast. And it's really important for that newborn baby to have that chin in against the breast. And going forward, if the mother's having problems. But, if your baby's gaining and there's absolutely no problems, the feeding's going well and it's comfortable, and your baby's doing, breastfeeding gymnastics, that's fine too. But it's only if there's a problem, bring them in.
And I think if they are gaining loads of weight, everyone reassures you and said, "Oh, your baby's fine. It's gaining plenty of weight," but it's not fine. They will gain plenty of weight if they're getting loads and loads and loads and loads of milk and lactose, because it's just sugar, and they'll just be like Michelin men, but they'll never be happy. And that's really important, that you're both happy and that you have a good experience. So go with it.
Alice is our next message, and Alice has been known to us in a team, and she said thanks for all your support to date, and thank you, Alice, for commenting and messaging. It's lovely. Her little girl is now 3 months old. That's amazing, and has had her first cold this week, resulting in reduced feeding. Would you usually recommend pumping during this time to ensure the supply is maintained? Thank you both. I think it would be a case of keeping yourself comfortable. I don't know what you think. I
think little and often is the way to feed a baby with a cold. It's it's a bit like you just have snacks when you're really bunged up. It's horrible, isn't it? But little and often.
I mean, if you're concerned, obviously you can pump. If you're sore, you could pump. But if you've got that supply there already, then it should mean your baby should be able to push it back up again when they begin to feel a bit better. Because as they begin to feel better, they'll feed. Your baby will feed a little bit more.
Only you know what your supply's doing. So if you feel it's dwindling, then get on the pump. And just do some pumping with, in between the feeds if it helps.
Yeah, I know it hasn't been straightforward for you, Alice. It's been, quite challenging.
I think also, if your baby is really snotty, the action of breastfeeding often opens up the nasal passages and helps the nasal passages clear. So you might find, if you have got a very snotty baby, that over the time of the feed, their breathing becomes a bit more relaxed once they've opened the passages up, with the pressure that's on the roof of the mouth with the good attachment tends to open up the nasal passages so that they have a bit more space, and the breathing often clears a bit. Or they get they sneeze and everything comes out because it sort of clears everything. So it has got benefits if you get them feeding. which they wouldn't get if they had a bottle. So, and also if you've not given many bottles, they have to learn how to use the bottle, which is a different technique, and that's quite difficult if they're feeling grotty as well. But obviously you only know your baby best, and if you need more to give them more and they're not feeding well, it's really important that you talk to your GP and get them checked. I think there's quite a lot of concern about the upper respiratory viruses that are going around, and the bronchiolitises. There's a really big outbreak with little babies at the moment because we didn't get any last year because no one was out. So there seems to be a double amount in this year. So if you have got a baby that's coughing and sneezing, snotty, make sure you get them checked if you have concerns and they're not feeding, because they go off very quickly, and they may need an extra bit of support from paediatricians. So just keep an eye on your babies and be aware of that at the back of your mind. If they get a cold, sometimes it turns into that respiratory virus that we're worrying about.
Right, Charlotte's come on and she's actually asking about food. Charlotte, you said that when you stayed last time you were hungry. What time are the food rounds? Well, we do. Not that I suppose it's about feeding, isn't it? It's feeding the mummies, which is important.
Yeah,
so
you're all coming into the hospitals.
So I mean, breakfast is usually around 8ish, and lunch tends to go out about 12:30, and dinner seems to be at 5:36.
Yeah.
But you can always ask for food.
Snack boxes are around all the time.
So we have the snack boxes, which Naomi's mentioned, which tends to be a sandwich and a piece of fruit. Or there are what are called light bites, which tend to be things more like your jacket potatoes or shepherd's pies, or sort of like cauliflower bacon, that sort of thing. But there is never ever go hungry.
Fruit as well, and I think there's is it biscuit bars or something? Is that available?
I think
sure.
the biscuits are offered as people get offered a cup of tea normally. Yeah. But the idea is that there were posters, because this came back from Oxfordshire Maternity Voices Partnership a while back, that mothers were saying to us that they were finding they were hungry because the mothers that are here are not ill. They're predominantly breastfeeding mums who need a lot of food. So they were finding they were hungry between the times that food was offered. Or the portion sizes weren't big enough for them.
I think also partners weren't allowed in, so they couldn't bring snacks in, because a lot of people go to the shops and bring food in to have snacks as well, and that wasn't allowed for a while. So we
had no visitors. So thinking about that from that point of view, obviously that's one way of dealing with it. But there is always food on offer. Just ask.
You shouldn't have to go and buy anything.
No, we can provide you with sandwiches. We can provide you with these light bites, and you get your 3 meals a day as well. So unlike our babies that get 8+, obviously. So I hope that reassures you, Alicia.
Charlotte, we do always talk about how many times you put food in your mouth, and the expectation that babies should only feed 8 times a day. But actually, if you look at how many times you put something in your mouth, it's probably about 16 to 18 times. If you look at all the times you put drinks, cups of tea, a cold drink, yogurts, biscuits, fruit, a main meal, a snack, it's nearly always about 16 or 18 feeds in 24 hours. So you can't expect your baby, if it suddenly says, oh, I'm a bit bored because you've just had a packet of crisps because you're bored, you say, I'm sorry, it's not time to feed your baby, it's not your feeding time yet. Actually, it's more than food. So babies do like to have comfort food just as much as you do. They like to suckle, and they like to be close to you. It's where they expect to be, and it's nearly always more than 8 times in 24 hours, just like it is for you. So unless you work like we do in the hospital and you don't get more than about 3 things in your mouth in a day,
we have managed to get lunch
then
quickly.
If you're a normal person, then you're going to put more food in your mouth than that at the end of the day.
Right, the next message is from Leanne, and she's put, Lyra's the queen of breastfeeding gymnastics. She waggles her leg like a lamb's tail, and I usually have one of her hands holding my nose. We learnt the phrase niplash from the OBS peer supporter, and it's the most accurate description for feeding a 10-month-old. I know, they're absolute terrors. They're little horrors at that age.
Head necking, aren't they? Rubbernecking. Absolutely. And I just love the way their toes move, you know, when their babies are feeding, their toes are just so expressive. They're just in heaven when they've got no socks or shoes on and their toes are just going up and down. Heaven.
Alice has said thank you. I'll pump anyway to be on the safe side.
Good idea.
Good idea. Brilliant. Okay, well that's it, I think, on the messages at the moment. Now we were going to talk about conflicting advice, weren't we?
Oh yes, absolutely.
Because that always comes back to us. We get that quite a lot, that people say, I've been given conflicting advice. And anyone who's watched this session before will know that we talk about how things change each day. So what you do on day 0 and what you do on day 3 and what you do on day 6 is completely different. So whilst sometimes it sounds like conflicting advice, it's actually often a different situation. So we're faced with a baby with our marble, which I think went on the floor, with a tiny weeny tummy.
Fall in front of the camera.
Yeah, so with a tiny weeny tummy that really needs very little, because colostrum is a food in concentrate, which we mentioned already. So we're talking tiny amounts, size of a cherry. But by the time they get to day 3, we're already talking about the size of a walnut, so it's a lot bigger. And mother's milk supply should be doing this in tandem. So the mother's milk supply should be going up in tandem with the size. It is a long way away. With the size of the stomach. So we've got our tiny marble and our slightly bigger one. So this is day 1, day 0. This is day 3. So we're looking at getting, increasing volumes. That baby's expecting increasing volumes quite quickly. So we do sometimes send you home, and many mums are keen to go home as quickly as possible without a baby attaching at the breast, and mums might want to go home and they'll be expressing into a syringe, because that tends to be what we tend to use in those early days, one of these tiny weeny 1 ml syringes. And we go home and we say, oh, it's fine, you can give 0.1 or 0.2, which might be, just here, literally just here on here. That's fine in the first 24 hours, but it's not fine in the second 24 hours and the third 24 hours. And that's where sometimes we get, we get told it's conflicting advice. The situation changes daily in the first few weeks of life after a baby is born. Thereafter it settles down. A mother's milk will settle down and she'll be producing on average 750 mils a day. I always think of that as a bottle of wine, because that's about what a bottle of wine is. So that's what
suggesting you know about that.
Yeah, I can't imagine why I might know. So you're thinking of, a standard bottle of wine is about 750 mils, and that's what most mothers will be producing on average. That's what they're going to produce. From, as Naomi said earlier, from about 4 to 6 weeks onwards, that's what she'll produce, and it doesn't change. So, and the baby's needs are met because the constituents of the breast milk are constantly changing to meet the baby's needs. But the first few weeks, the situation is constantly changing. And if we met with a baby that on day 5 has lost more weight than we hoped, then we're going to put a big feeding plan in place. And if that baby's lost again, or static on day 7, or not gained quite enough, because we want them to gain from day 5 onwards, we're going to put another feeding plan in place. So the situation does keep changing.
And that feeding plan will be different, and we will step it up so that you have to do more and more.
Yeah.
And that gets harder and harder because, it's hard work trying to make milk when you're catching up. If it hasn't been great in the first few days, and it's what I talked about right at the beginning, is that, the sooner you start doing it, the less effort you have to put in. But the further away you are from the birth and you've got supply issues, the harder you have to work to make it. And so it's about you being proactive. It goes back to you being proactive as parents, that recognizing and making decisions yourself about whether you think your baby's getting enough. On the care plan that we talked about in the page in your care plan, that's telling you those are all the answers you need to know on day 1, day 2, day 5, day 7. It's all there telling you that you have to make decisions clinically as parents about food and volumes for your baby, and not wait for somebody to come and do them. But actually then what happens is we become quite prescriptive, and depending on who you're seeing, it becomes probably more prescriptive. So if it's one of the care assistants in the community comes in and says, well, actually you need to do this, they'll put a plan in place, usually a very comprehensive plan, and then you come back 2 days later and that hasn't worked because it's not quite enough for your baby. You haven't quite got enough milk, your baby's not quite feeding well enough. The next thing will be that they may ring us, and we may then say, well, actually that's great, but actually just add this and this and this, see how that happens. and then you go away and you work like Billy O, and you're absolutely shredded because it's 24 hours on, 7 days a week. It's really hard, and you come back and the weight is done again and it hasn't quite worked. So then you start getting somebody else saying something else, and that can also be perceived as conflicting. But actually, depending on the level of speciality that you're seeing, the plan will be changed. And we do quite often get people saying, well, my health has just put a really fantastic plan in place, but you come to see us as specialists, and you often don't like the plan that we're giving them because they've been told something else, and they say, well, that's the plan I've been told, and that's I've said if you switch feed you don't empty the breasts properly, and then it's a problem. But actually, I always say to them, it's an advanced breastfeeding class when you come to us. You're in the sort of early breastfeeding, and then you come to us and it's an advanced class. It's advanced breastfeeding, and so you really step it up and you do something different, and you have to do something different, because if you don't do different, you don't see change. And so you have to step it up to get to that level to make it better. And that's the bit that's really conflicting and really demoralising for an awful lot of parents when they're having this advice changing and they're getting confused, because they just, when you're a postnatal mum, you can't take on board instructions at all. You're in your right brain, you're really fuzzy, you're in this baby moon where you're trying to bond with your baby, and you're not allowed pajama days because we're weighing your baby every 5 seconds and coming in for appointments every 5 seconds, and it's just shredding you, plus all the pumping and all the topping up that you're doing. You just don't know whether you're coming and going, and so you don't always remember the order in which things happen, and then something else is put onto the agenda, and it almost tips you over the edge as giving you something else to do, doesn't it?
Should we have the care plan again? Because that's where the plan should be written. So if you are having a plan written by one of us or a community midwife, the plan should be written on that page. And I know it's back to front for you, but you've got the observed breastfeed, this is where the hand expressing has been signed off because hopefully you've been taught, and then the plans go in on these pages. So we as a team will always write on here, and the community midwives will predominantly write in here too, as well as the ward midwives. So this is here for you as well as for us. So when I send mothers home, having seen them, whether it's on the ward or in our outpatients clinic, I will always put the plan in, and I always read it back to them, and I will put the things in that they have struggled with. So I mentioned, talking about nose to nipple. I had a mum this morning who really didn't quite get nose to nipple, so not only did we take pictures of her feeding, so we took pictures of her positioning attachment, I wrote about it as well. So I said to her, the plan is here, will help you so that you can refer back to it, so you've got it easily accessible. The other thing I will say is that when it comes to conflicting advice, I'm not going to say that everybody in this trust, because we are a very big trust, says exactly the same. We don't, unfortunately. It would be lovely if we could all say the same. But sometimes there's a benefit in saying it in a slightly different way, where we'll mix up sometimes. One of us will go and see somebody and feel like we're not getting through to them, and the other will go and it works perfectly. It's a bit like sometimes you're speaking a different language, but just the way that one person says it makes sense, whereas somebody else it didn't. So
it's just your learning styles.
And we are all different, and we have different teaching styles. So so it is trying to meet the person's needs where they are. But we are aware that conflicting advice is something that comes back to us quite a bit.
I think if you get the same thing said to you differently in 4 times in one day, and somebody says conflicting advice 4 times in one day, then that shouldn't be right.
No.
But if you get it every day changing, then that probably is right, because your baby's needs are changing. But at the centre of the care, you're the key players. As parents, you're the key players, and your baby is your dyad. It's mother and baby are together, and you're a dyad that stay together, and you are the key players in that dyad. You're the ones that should be the lead in your baby's needs, unless your baby is clinically really not well and you need to have really much more input. But actually, on a day-to-day basis, when you're at home, it is you that should be making the decisions from the day you have your baby, from the day you get pregnant. Really, you have to make decisions about all sorts of things, whether you want scans, whether you want tests, whether you want vaccinations, where you want to have your baby, who comes to see you, your visitors, immunisations. It is ongoing, and it continues throughout your baby's life and your life. And it starts when you get pregnant and continues. So when you go home, or indeed when you're in the hospital, you shouldn't be waiting for people to tell you what to do, because you are the key players in your baby's life. You make the decisions, and we're there to support you and prop you up, but we're not there to tell you when to feed your baby. You should be making those decisions. We can come in and say, actually, do you think it might be better to feed a little bit more often? But you make decisions about it. You shouldn't be saying, oh, my baby slept all night, nobody told me to feed it. You should be saying, when do I feed my baby? How many times a night should I be feeding my baby? And you should be looking at the clock and working it out yourself, that actually in 3 hours time I probably need to wake my baby up again if it hasn't woken up. Or, I need to give more food because actually they drained what we gave them if you're topping up, or they didn't feed very often. I perhaps need to do more feeding today. The nappies and things, and go back to the care plan. That tells you all of those things, and you can look at the care plan yourself and say, tick, 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 that's not happening. What should I do about that? Not wait for somebody to come and tell you, because actually it's your baby, and it's a really good learning environment to make decisions about your baby when you're in a safe place where you can ask for advice more easily round the clock. And then by the time you go home, you've been doing it for 24 hours, 48 hours before you get home, rather than being spoon-fed, saying, feed your baby now, do this now, change your baby now, put a blanket on your baby. Think about all the things that you need to do as parents all of the time to make sure your baby's been fed and watered and comfortable, and what its needs are, because you'll be confident when you go home and there isn't somebody there to ring a bell and ask. So it's a good chance for you to learn and make decisions, and it might not be the right decision, but somebody can come in and support you like a safety net and say, well, that's a brilliant idea, but I would say maybe just feed a bit more frequently, or perhaps you need to change your baby more frequently. Hopefully that makes sense.
So yes, because we know it's something that comes up a lot, is that people talking about conflicting advice. But it's been very quiet on the questions front, and it's 3:30. So we've both got to go and write up our notes from our breastfeeding clinic appointments now, so that they can be there for anyone else to access if need be. But if any other questions, chuck them through right now, otherwise we're going to be saying goodbye. I know it's not been a great month, January, but we've got another week off next week, and then we'll be on for a nice long run of a good few weeks before we have any more breaks. As I think I mentioned last week, we're sort of in need of taking our own annual leave, and so it means that sometimes we're not both here, which makes it slightly more difficult. Questions? Is that it? I can say thank you to Alice and to Leanne and to Charlotte and to, who else did we have? All the lovely people, lots of regulars.
Brilliant questions.
Amy.
Lovely, and keep the questions
Vicky,
coming, and if there's anything
Rachel.
that is touching a nerve and you just want to check,